Welcome to my Pecha Kucha presentation on PTSD. PTSD is a condition that many people I know have been affected by. In this presentation, I hope to highlight causes, signs and symptoms, treatments, and finally, PTSD's relationship to chronic pain. PTSD is defined by Wall and Melzek as an anxiety syndrome following exposure to an extreme traumatic stressor to oneself or another person. The lifetime prevalence of PTSD is reported to be about 8%. However, prevalence has been reported to be 7 to 39% in chronic pain patients. PTSD is a disease that is commonly associated with the military. The population of veterans with PTSD has increased with the recent wars in Iraq and Afghanistan. The Office of Veterans Affairs states that between 11 and 20% of OIF and OEF veterans experience PTSD in a given year. Those who are most likely to develop PTSD are those who have been exposed to trauma as a victim or witness, were hurt during the event, believed that themselves or loved ones were in danger, felt helpless, and/or had a severe reaction during the event, such as crying, shaking, etc. People are also more likely to develop PTSD if they have had a previous trauma, have another mental health problem, have little to no support from family and friends, drink excessive alcohol, are a young woman, or are poorly educated. The prevalence of PTSD is also more common in African Americans and Hispanics. There are generally 4 categories of symptoms in relation to PTSD: reliving the event through flashbacks or triggers, avoiding situations which can bring back memories, negative changes in beliefs and feelings, and hyperarousal which can cause jitters, easy startling, or difficulty sleeping. A more specific list of symptoms includes agitation, irritability, hostility, hypervigilance, self-destructive behavior, social isolation, flashbacks, fear, severe anxiety, mistrust, loss of interest or pleasure in activities, guilt, loneliness, insomnia, nightmares, and emotional detachment. Suicide is a serious concern with those who suffer from PTSD. One study found the suicide rate in the U.S. Army in 2009 was 20.2 per 100,000, which was the highest ever recorded. A significant number of those suffering from PTSD do not seek treatment, but are at increased risk for suicidal ideation, attempts, and completed suicide. Selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors are frontline pharmacological treatments for PTSD. Other antidepressants are sometimes used as well. These medications seek to improve the balance of neurotransmitters in the brain and are taken indefinitely. Non-pharmacological treatment of PTSD includes, but is not limited to, cognitive behavioral therapies such as prolonged exposure therapy, stress inoculation training, and eye movement desensitization and reprocessing therapy. Traditional counseling and group therapy sessions are also employed. The Department of Veterans Affairs has established an extensive network of resources for veterans suffering from PTSD with the increase in cases recently. An average of 22 veterans commit suicide each and every day. The Department of Veterans Affairs has taken notice of this statistic and developed resources accordingly. Resources for non-veterans suffering from PTSD are the same as seen with other mental health disorders. Patients are often met with significant wait times to see a mental health professional. Mental health funding continues to be a hot topic due to already implemented and proposed cuts. Lack of treatment for PTSD could mean life and death. Population-based surveys have demonstrated rates between 62% and 92% with depressive disorders, substance use disorders, and anxiety disorders consistently emerging as common PTSD comorbidities. Comorbidity with PTSD has been found to be associated with increased risk of functional impairment and disability. A study was conducted to investigate chronic pain patterns in Vietnam veterans. Combat veterans with PTSD completed standardized PTSD severity, pain, somatization, and depression measures. Of 129 consecutive outpatient combat veterans with PTSD, 80% reported chronic pain. People with chronic pain and comorbid post-traumatic stress disorder report more severe pain and poorer quality of life than those with chronic pain alone. Participants with PTSD reported more use of several coping strategies, including guarding, resting, relaxation, exercise, stretching, and coping self-statements. Pain following the aftermath of a traumatic event is a risk factor for PTSD. PTSD and pain have been shown to have mutual maintenance. This interaction can have a negative impact on the treatment of each disorder. PTSD symptoms have a direct influence on the severity of depressive symptoms in chronic pain patients. Studies have shown that PTSD symptoms in chronic pain patients have been associated with increased pain, affective distress, and physical impairment or psychological distress. The relationship between pain and post-traumatic stress disorder could be mediated by depression. All of this evidence suggests chronic pain patients should be evaluated for the presence of PTSD. If PTSD is present, they should be asked if pain was present after the event. Chronic pain patients with PTSD should be evaluated for depression, panic, and sleep disorders. Undeniably, PTSD is a significant risk factor for chronic pain. PTSD is a disease that is commonly thought of as a military-only prevalence. However, this disease can affect anyone that has been involved in a traumatic event. Psychiatric comorbidities and chronic pain are commonly associated with PTSD. A better understanding of the disease and methods to treat it are beneficial to chronic pain practitioners. Thank you for viewing my Pecha Kucha presentation on PTSD. Through this presentation, I hope that I have enlightened you to some of PTSD's causes, signs and symptoms, treatments, and PTSD's relationship to chronic pain.